The Community Hour on 99.8 Hours FM.
A very good afternoon to you all. Welcome to the Community Hour here on Hours FM Community Radio. Thank you for joining us. And once again this week we have our specialist with us here in the studio via Zoom. And for those of you guys who have been listening to us last week, where we spoke a little bit about the COVID vaccine and why it's important for BME communities to take the vaccine, just a little recap. It is important because of the number of people who are dying because of the vaccine, because of COVID, and how the vaccine is actually supporting us, helping, and why BME community are lacking in going to the GPs or going to the hospitals and getting the vaccine. So we was talking a little bit about that last week. This week we're going to be talking a little bit about the vaccines itself and why and what is a vaccine and why they are so important in the world today. And with me I have my three experts. I have Dr. Ayman El-Zetani, I have Professor Anup Johan, and I have Sol Forst with me here in the studio via Zoom. So if I can start with you, if we can first just do a little recap on last week, and then if you can explain to me what is a vaccine.
So vaccines are one of the great healthcare innovations of the 19th and 20th centuries. So vaccines are a way of stimulating a body's immune system against an infectious disease to stop infection. So in the world, we've eradicated smallpox, and we control things like measles and diphtheria and whooping cough and meningitis using vaccines, which we give to babies and adults for different things at different times. And our grandparents and their parents used to have friends and relatives die of infections all the time when they were small. And we've managed to stop that now across the world with vaccines. And
one of the questions that was coming up last week was that we have managed to find a vaccine for COVID so quickly within the space of a year, but cancer and other sort of things, we haven't managed to find vaccines for those. What was your reply for that?
Yeah, well, cancer is not an infection. The reason why we've been able to find these vaccines so quickly is partly because of modern technology, being able to understand COVID immediately, it came out. And secondly, because we stopped doing any other research. All we've been doing for the last year is COVID research on the drugs, the treatments, and the vaccines. And that's been to the detriment of other conditions that we've stopped researching in, but it's meant we've progressed really quickly for COVID.
I mean, one of the questions that came up afterwards from our listeners was, look, you said that everything else has stopped, and here we are, everybody is concentrating on COVID-19. But that was the case when it was polio, and that was the case when it was other sort of infections, and they didn't find it that quickly. We still haven't got one for AIDS. HIV.
HIV is a very different virus, and we were lucky. The honest answer, Ali, is that the spike protein that we make the vaccines against, we've been really lucky that they work. As people know, we have flu vaccine that we give every year as well, and that's not that effective. It stops people coming into hospital, but people still get flu. So it's been really fast because everybody's concentrated on it. And we now know, since we last spoke, we've given vaccines to nearly 13 million, I think today, people in the UK, if not over 30 million. We know they're safe now because we've given them to so many people worldwide.
I mean, you say we are really lucky that it's worked. So is this a fluke that went right?
I think whenever we're making vaccines against infections, and you have to choose at the beginning what you're going to make the vaccine against, because you don't want to give and the world, the different companies all started making vaccine against the spike protein. And yeah, we've been really lucky. The whole world's been lucky that the vaccines against the spike protein have worked.
So you keep reiterating spike proteins. Can you explain the difference?
Yeah. So everybody's seen the picture of the coronavirus on TV, right?
They're pretty scary.
Small thing with the things that the spikes are on the outside, that's the spike protein. And they're bits of protein that the virus makes that help it get into the human cells. And what we do with a vaccine is we simulate the spike protein and we join it up with other things that stimulate the body's immune system, but can't give you COVID. And these are temporary things that the body just gets rid of. And then the body's immune system, the T cells and the B cells, make antibody against the coronavirus by making antibody against the spike protein. And then the other thing that vaccines do is not just make the antibody to help you fight the infection directly, but they stimulate the body to remember how to recognize COVID next time you see it. And we call that memory. And that's why vaccines are so good at protecting people for a longer term. And it might be that we need boosters in the future, but we don't know yet.
Okay, so one of the questions that did come up, we did have on the memory RNA vaccines, which we'll come to a little bit later. But Professor Johan, if I can come over to you, explain to me. You see many patients, but there were 22 residents who died within the space of 3 weeks in Basingstoke in Pemberley House, which is a care home. And it's understood that this occurred just as residents started to have their vaccines. What's your take on this?
I think it's unfortunate. We're obviously very sympathetic with what happened there as well. So what it tells us is several things really, that those vulnerable elderly people in care homes are at highest risk, and therefore these are the individuals who should be receiving the vaccine. These deaths occurred at a time when the pandemic was at its most rife. The number of infections in the community was really high. And I would view that the whole story was as a result of those poor residents not receiving the vaccine early enough. Not directly as a result from the vaccine, but not soon enough. The best analogy you can have here is imagine you have a house and you're in the middle of a forest fire, as you've seen in the bushfires in Australia, and you know that you could put the fire out with a water pump that's outside the house, and you run out and get the water pump and you try and put it out, but unfortunately you succumb to the fire. Do you say because they died because they went out to get the water pump, or they died because of the fire or the infection? So that's the analogy. I think these poor people did not receive the vaccine early enough.
So is somebody at fault for that?
No, not at all. I think the whole country and the whole pandemic response has been good, and we've been prioritizing those people who are at highest risk, so those in care homes, healthcare workers, and the elderly. And these are the people who are at greatest risk of dying, and these are the ones who need the vaccine the most as well.
And Ali, remember,
yeah.
I mean, just to come in on that, Ali.
Yes, please.
13 weeks ago, we didn't have a vaccine at all, right? And then it had to be distributed. We started immunizing the last week of December. That outbreak in the care home in Basingstoke started on the 5th of January. So that was right at the beginning. We were trying to give those people the vaccine as quickly as we could. But as everybody knows now from reading the papers, it takes 2 or 3 weeks to build up immunity before the vaccine takes hold. So it's, as Anoop just said, it's just really unfortunate that they weren't given the vaccine in time.
But this vaccine, they had the vaccine, and these deaths occurred 3 weeks later. So they would have had some sort of immunity, no? Professor Chan?
I don't think that's right, Ali. I think the deaths were all, the outbreak started on the 5th of January, and it will have just ripped through that care home, just like Anoop was describing with the forest fire. So although there were people who died a bit later, that's because COVID takes hold, and it is a bit of a longer disease. As we know, you get sick for a week and then you become more sick. You don't die straight away. So it does, we have to look at the whole country now, and the fact that we've immunized so many people with the vaccine, and we're just starting this week to see the number of old people in hospital come down, which is really great.
Okay. Dr. Al-Zatani, Norway is also investigating the death of 2 nursing home residents who died actually after they were vaccinated. What's your take on this?
So I think the story there is they might have had some sort of, there was some talk about some side effects, diarrhea and other things, which we know diarrhea is may not necessarily in itself be a severe illness, but if you have it in an old person who could be dehydrated, not drinking enough fluids, whatever, it can become a bit serious. And so in the best of times, and we know that the winter pressures, normally the flu can come as a respiratory illness, but some people have flu as a gastrointestinal illness, and therefore um, those kind of situations in somebody who's very fragile and vulnerable can cause rapid deterioration. So it's whether it's we obviously any case of death following a medicinal product will usually have to be investigated properly, like we have here, and sometimes coroners as well get involved with that before they actually have a full cause of death. And correlation doesn't mean causation. Somebody having a vaccine now and then dying doesn't necessarily mean that it was the cause of it directly or indirectly. Before you know all the
We sort of lost you there.
You froze.
You're
There. I
frozen.
think the second
yes.
part of that question is, look, 3 or 4 weeks ago, we were worrying about whether allergy was a problem and whether there were going to be side effects. The vaccines have all been trialed in over 150,000 people now in trials globally. But we've given the vaccine across the world.
But these are controlled trials. These are controlled trials, not actually proper trial per se.
So a controlled trial just means we know what we're giving and we're keeping a very close eye on people when we do that. We now know that we've given the vaccine to tens of millions of people across the world. And in the UK, the Medicines and Healthcare Regulatory Agency, they get reports of all the side effects. And they announced last week that they'd studied the vaccines that have been given since we started the program in Britain. And there have been no instances of any serious side effects attributable to the vaccine in the UK. They were very clear on that. They're being very open. Doctors and nurses report any serious side effects. And we're absolutely certain there's nothing been seen in the UK from either of the two vaccines that are being used at the moment.
Okay, so what sort of side effects should we be expecting?
Anoop, do you want to take that one? I've talked a lot today.
The side effects are minor. Some people who receive the vaccine can expect to get a slight pain where the area of the injection, but that only lasts for a day or so. And that usually settles. They might get a slight fever, but that's about it. So there are symptoms that are very minor in the majority of people.
But is that the same side effect for all the different vaccines that we have, or just specific?
I think every vaccine, not just COVID vaccines and the 3 and the 4 that we have, but others, the common local reactions, because remember, what we're trying to do with the virus is induce an immune response. And the way that the body boosts this immune response to try and fight the virus is by causing some of those side effects. So the pain is actually a good thing, and it's showing that the body is mounting an immune response, which then settles as well. So these side effects, very minor ones, are not new for COVID. We see that in flu and all the other vaccines. So nothing unusual about COVID.
Professor Johan, what happened to the flu this year? It seems to have disappeared, and nobody's talking about it.
Well, it's still there. It's like every virus. A virus doesn't move. People move the virus from one area to another. So what we found is that the flu virus is not going to get spread because of all the precautions people are taking because of COVID. So washing their hands, social distancing, masks. So those same measures that prevent COVID, the same measures prevent flu vaccine. That's why we're not seeing as much of it.
Are we seeing it, or are we just not seeing it at all?
Actually, the data on the flu vaccine shows that it's actually very minimal, a lot less than we'd expect at this time of the year. So there may be 1 or 2, well, there'll be a few cases, but it's certainly not in the same proportion as we were fearing before the winter. So thankfully,
Okay, that sort of sounds like you're saying that during the winter we don't wash our hands and so on.
Normally,
yeah,
that's true.
absolutely. Yeah. Well, what about 2 years ago? You know, we didn't practice masks and washing hands in the same way that we do now. And that's why we had the flu virus. The fact that we're doing all of that now means we're not seeing as much flu. And thankfully, we're controlling COVID in the same way with those measures.
We was talking earlier on about the vaccines and the different types of vaccines. So how can anyone say that the messenger RNA vaccines are safe when actually there is no long-term clinical studies of it?
Yeah, well, there aren't any infections. People have been studying mRNA vaccines for some time, Ali, by trying to find cures for cancer, believe it or not. And people hadn't really focused on infectious diseases for that technology. But they're like snap-tap messages. mRNA is a very, very unstable molecule. That's why for one of the vaccines, it has to be kept in the freezer at such cold temperatures. And it behaves like a Snapchat message in the body cells. It gives its message to the body to make the protein, and then it disappears. And by doing that, and it makes a little tiny bit of the spike protein that just tricks the immune system into thinking it's seen a coronavirus when it hasn't. They're actually really good at stimulating the immune system in a way we didn't expect, and we were really pleasantly surprised that 2 have now been approved, and there'll be more mRNA vaccines coming from other companies. But it does appear that they should. There's no reason to think that there's going to be any long-term side effects for these vaccines any more than for any other vaccine. And we know, as I said right at the beginning, immunization with vaccines is the one of the most unbelievable healthcare inventions to stop children and old people and healthy adults dying over the last 100, 150 years.
People are saying that the messenger RNA vaccine alters your own DNA.
It's impossible. It can't get in. So DNA is very different. DNA is the body's genetic code, and we make mRNA in our body from the code that the DNA gives us. So the DNA tells the body which mRNA to make. You can't turn mRNA into DNA in the body without giving a whole series of complex chemicals that would do that chemical reaction in the body. So that's just not going to happen because it's impossible.
We've seen lots of videos of people, saying they've had the vaccine and then they do that. So
they're making it up. Yeah. They're making it up, Ali. This is dangerous stuff, because it's just not fair on the population to have these sorts of rumors spread by social media or on videos or the internet. I think it's really what we're trying to do with this show tonight is bring 3 of us together with you to really explain the facts, because there's so much information that's being passed on WhatsApp and Facebook and really just such a lot of lies that are going to kill people and harm people if people start believing the rumors.
So, Professor Joanne, Saul's just explained a climate of mass media propaganda and censorship. Organizations like Facebook and other social media platforms don't really seem to want to stop this or are not able to stop this. So how can people make, the average person, how can they make a proper risk assessment of all of this?
So I think it's an important point for us to choose the areas of communication, the people we get our information from. So at the moment, the government advice is very clear around vaccines and what social distancing and all the other things we need to do around that. So we would say that the reliable sources of information will be healthcare professionals, which will be also the information that we're getting from the Public Health England and also the government. So that's the sort of reliable, solid advice that's been through committees and a body of experts and individuals who are giving this high quality advice. Be very careful of what you see on social media that's unsubstantiated and that goes completely against the grain in some areas. And quite rightly, in those areas where they're spreading not just misinformation, but actually real lies. As Saul said earlier, the mRNA doesn't enter your cell, it doesn't alter your DNA in any way. And the mRNA is very specific for the spike protein. Yet on Facebook, we're getting everything from changing your DNA, people getting unusual reactions. So all of that is very dangerous. So I would urge people to be very careful around that, but also if they're unsure about any information, speak to your nurse or your doctor, who's a reliable source of information, and they will give you the best possible advice that's good for you as well as the community.
Dr. Ayman, Dr. Al-Sultani, welcome back. I know you had a little bit of a problem with your Wi-Fi. One of the things that have come out is the benefit or the not so benefit of lockdowns, and there was a survey done by Stanford University, and they felt that there was no real benefit for severe lockdowns. You're on the front line. What's your take on this?
Well, we know that, hospitals have always been places where we have outbreaks. The public might have experienced what it looks like an infection which can spread around and an outbreak at a large scale. But the hospital has always had outbreaks of of wound infections, of diarrhea, neurovirus. So we have many, many years of experience in dealing with outbreaks. And we know the measures which work, and that includes what you call now the social distancing of the lockdown. So translating lockdown into practical measures is washing your hands, covering your face, and having social distancing is what day in, day out we do in hospitals when we are faced with local outbreaks. But the hospitals carry on working because they implement measures in the area of the hospital which has had an outbreak by locking it down in a sense, because we control who goes in, who comes out, and when they go in, what they do, when they come out, what they do. And that's why the hospital can carry on functioning.
Yeah, but
so
we keep
hearing. If you're looking at what we're doing now on a countrywide or worldwide, is basically a big example of what lockdown can do until we get control of the outbreak. And it has been time tested very successfully over many, many, many years. Since I've been in the NHS 30 years ago, every winter we have 1 or 2 wards which are closed up because we want to carry on working the rest of the hospital while we deal with this outbreak in that ward. And that's why we lock it down. And that's why we would like the country to go through that kind of situation until we work it out. And the solution is now at hand, which is the vaccine. Once we have enough people vaccinated, then we can think about easing those measures. So I think it is important.
We keep hearing the NHS is going to be overwhelmed. It's coming to breaking point. It hasn't broken. We haven't got there. It's just scare tactics, is it not?
Well, no, because we are basically what we're looking at now is really pushing the problem and pushing our admissions and our non-life and limb care down, down the road. So I think what you're having now, all the non-cancer surgery, all the elective work, elective admissions, elective treatment have been suspended in essence till we deal with this problem. So we've created capacity on the expense of a lot of people with hip problems, eye problems, other problems which needs to be treated. They're not getting that treatment. And we're going to have to spend the next 12, 18, maybe a couple of years catching up with all those things which we haven't operated on. So I think we are creating capacity on the expense of people who need worthy treatment, those who are suffering from their hips and knees and other problems. They are all waiting for this to settle down and so that they can come into the hospital and have sort of their treatment. So it's not like we haven't suffered as an NHS in service delivery because of this. We have, and our patients have suffered as well.
Okay, so there are 3 types of vaccines at the moment, and more coming along as we speak. which one of the vaccines work the best? Because we've now seen some evidence to say that not all of them work as much as what we were told they work. Some of them don't work as effectively.
Yeah, this is really, really, really confusing for the public. The bottom line, Ali, is that they're all equally good at stopping hospitalization and death. The numbers that are being bandied about are about the ability to stop you getting COVID at all, even mild symptoms. But what we know from all of the vaccines, the Oxford one, the Pfizer one, but also the ones that are going to come down the line, the Novavax vaccine and the Janssen vaccine and Moderna, these all of them.
Even Moderna has had some negative.
All of them stop people going into hospital and stop death. And that is why people should have the vaccine. Now, in the course of time, we'll find out how good they are at stopping transmission between ourselves. We know that the Oxford vaccine is pretty good at
how many people are going to die in the course of time whilst we wait for this results, as you say?
No, they're not. Because if we give the vaccine to everybody in the country, then we'll take the pressure off hospitals because the personal protection will be there. And the vaccines also stop the death and hospitalization, even in the variants, all right? There's no issue with the vaccines and the variants to stop the hospitalization and death. And there's this horrible noise in about whether they work in old people or not. The WHO this afternoon have approved the Oxford vaccine for use in all age groups, even the elderly, globally, even where the strains. Now, the World Health are a problem. The World Health Organization have done that because the vaccines are providing personal protection. And you know, in the last few weeks, we've immunized 13 million people in Britain. By the end of July, August, we'll have immunized every adult in the population. And hopefully then we'll be able to move into more normal life next winter. We might need a booster. We'll find out nearer the time. But by next winter, we're hoping in the UK, COVID will be a bit like flu. But that depends on everybody having their vaccine now. It really does. And the nonsense that's being talked about, choose this one, choose that one, is just nonsense. Have the first one and that's offered to you because it'll stop you going into hospital.
Yeah, but some of them, you know, well, say for example, the Pfizer one, you have to take two.
Yeah.
The other ones, you only take one.
No.
So why can I not choose the one?
All at the moment, all of them you have to take take two, I beg your pardon. So the Pfizer, Moderna, the Oxford vaccine, and the Novavax are all 2 doses, and they'll be 2 to 3 months apart, the doses. The Janssen one that was talked about on the news a couple of weeks ago might be allowed to be done on 1 dose, but we haven't got any in the UK yet, and we don't know when it's going to arrive in the UK. So at the moment, we just have to take the ones that GPs have and the hospitals have to give.
Countries like China have got their own vaccine, which is working really well, supposedly.
Working the same as ours. It's doing the Sinovac vaccine in China is very similar technology to the Oxford vaccine, to the Janssen vaccine, to the Russian vaccine. Ali, it doesn't matter. The world needs COVID vaccines, and ultimately they need to be tested and made sure to be safe. But it just doesn't matter which one people are given. You should have the first available. I can see Eamon's trying to come in now as well.
Yeah, please, Eamon.
So I was going to say, actually, if going back to the initial premise that vaccines are boosting your immunity, it makes a lot of logics and biological common sense that you need a booster. Now, at the moment, we know that the first dose of vaccine is giving you some immunity, which is decent enough and far better than whatever any flu vaccine we've given over the years. So having a second dose, even with the vaccines which are given at 1 dose, and I think Saul will corroborate that, is that having a booster sometime in the future, within 3 months or 6 months or next winter, makes a lot of biological sense, because your immune system needs to be kept at a ready level so that it can deal with any kind of upsurge of infections. And therefore, I think when we are setting the kind of the body ready for any kind of virus onslaught, and then that's the first step. And then the booster dose when it comes in, and if we have some boosters in the future for the variants, then it just means that we are not starting from nothing, which is what the problem was with Corona, is that we had no idea about our body was not used to this kind of virus. Now we need to just to keep up with it, and hopefully our immunity will build up sort of over the months and years with these.
What's stopping us from what's so less in the first dose that we have to have a second dose? I mean, is it like 50% of it that we're having now and then 50% later? What's so less that we have to have a booster later on? Why can we not have all of it in the first one?
It's the way your immune system works, Ali. And we know that boosters are the way of getting the best possible immune response. So when you first give a vaccine, the body's never met COVID vaccine before, and the B and T cells make a bit of antibody and they put themselves into this memory state. And that's called priming. The second dose, 2 to 3 months later, then stimulates, gives those cells an even bigger kick and really gives you a much better antibody level and then that goes down over time, but it lasts much, much longer and is a much stronger memory response. So what one of the vaccines has done, they think they can get protection with 1 dose, but they're doing a 2-dose study as well. We're doing that trial in the UK because even that company think that they're going to need further doses in due course. It's just to stop the pandemic. For one of the vaccines, 1 dose might be enough. And you know that for the other ones, having 2 doses is no big deal, is it? We just go back for a second appointment. And as Anoop was saying earlier, your doctor's going to be booking you in for that at some point after your first dose.
Dr. Al-Zahtani, there have been suggestions of alternatives to vaccine, like for example, taking vitamins. What's your take on this?
Yes, so I don't think it's comparing like for like, because what you're trying with vitamins, like, is to make the body overall function better. And we know that some people who have maybe a vitamin deficiency may be more vulnerable for certain diseases and overall weakness and vulnerability, but it doesn't specifically target the problem at hand, which is a specific virus which attacks you in a specific way and cause a certain set of diseases. And that's why you can overall make the body fitter with some vitamins, and mainly if you have deficiencies. I think people who have normal, healthy diet, who have no vitamin deficiency, having more vitamins is not going to make you extra strong. And I think the vaccine is more specific and targeted to the disease itself. So I would say that you cannot protect yourself with vitamins against specific disease.
It's been suggested that, you know, if you had vitamin D, if you had a little bit of zinc, if you've done a bit more exercise, had a healthy diet, you're going to make your cells, give them more fighting power. Maybe not make them stronger, but at least they'll be having more fighting power.
I wouldn't say that having all those things you mentioned are not good for your body as a whole. But we know in medicine generally that the moment you know where your attacker is coming from and specifically target him and target that avenue, you're more likely to have a better response, which is strong, overwhelming, and stop that disease in track. Having to spread your defenses thin and by just giving yourself general sort of fitness doesn't necessarily guarantee you protection against a specific a specific disease. And that's why I think those measurements are definitely not a panacea, not a replacement for the vaccine and the other interventions which we are using if you eventually have the disease. So you need to be more targeted and more specific, and that's what the vaccine is all about.
Professor Chauhan, Matt Hancock, our brilliant health secretary, has ordered a review of the link between vaccines and vitamin D. And apparently, Matt Hancock had previously said, and I quote, a number of studies indicate vitamin D might have a positive impact in protecting against COVID-19, unquote. And Public Health England has said only last month that it may also reduce the risk of respiratory illnesses.
Yes, so vitamin D is something that we use in our practice quite commonly. So going back to the earlier point as well, all the things that you mentioned above, exercise, a healthy diet, having enough vitamins in your diet, including vitamin D, they all boost your immune function. So even less stress and more exercise, losing weight, they all in some way contribute to boosting your immune function. And that's what we're doing with the vaccine. So if you can imagine, if you put all those things together, along with an effective vaccine, you're more likely to get a better response as well, simply because of all the other conditions that are there to make sure that you benefit from that. So going back to the vitamin D thing, is something that we've been using in our practice for a long time. In the same way that vitamin D helps you boost your bones, healthy skin, we believe that it also boosts your immune system in the same way. So it's actually welcome from Matt Hancock that is doing a review in this, so we can really scientifically study and hopefully confirm the benefits of vitamin D in protecting against not just COVID, it's possible against other respiratory viruses as well.
And your take on what Public Health England has been saying? That it reduces the risk of respiratory illnesses?
Yes, we do. So we know from the areas and patients that I look after with asthma and COPD, I prescribe vitamin D quite commonly in some individuals who are at high risk, who have been shown to have low vitamin D levels, and we do get a good clinical response. However, Ali, it's like everything else. When you've got a question like this to answer, what do? We do research. And we wouldn't have any of these treatments, dexamethasone or the vaccines, without research as well. So I just want to re-emphasize the importance of people participating in any research trials that the doctor or a care worker might offer them, because all of this knowledge will be used to help us advance treatments in this as well. So back to vitamin D, I think it's welcome. The early data is very good, but we need to do more research on it.
Talking of research, so you do a hell of a lot of research. Tell me about the alternatives to the vaccine. Some people have been mentioning a new product which I've not heard of, ivermectin.
Ivermectin.
Tell me about this. Tell me what it is first.
Ivermectin is a drug that treats some tropical diseases, and some people have had the idea that it might work against COVID by helping stop the virus replicate. But you're absolutely right, it needs to be done in clinical trials. In fact, the manufacturer is so insistent on it, it's recommended not using it outside of a clinical trial. But the UK GPs are doing a trial called the Principal trial, which might well be adding ivermectin to the testing regime. So if people get COVID, and the principles for people who are over 50, and you can either go via your GP if you get a positive diagnosis, or look at the website for the Principal trial for COVID in the UK, and you can self-refer. Ivermectin's not on there yet, I don't think, and Newt might be able to tell me the exact timeline, but I think it's coming in the next few weeks. But you'll get offered a trial of one of the drugs that people think is going to work for people with mild COVID in the community. And one of those is an inhaled asthma drug called budesonide, and ivermectin's going to come online soon in the next few weeks.
Is that something that's being trialed or something that's now being used? Being
trialed, both of them. The trials are very, very important, because unless you do the trial, you don't know whether it works in clinical care. And Anoop can tell you about the change in his practice in the hospital with adults with respiratory COVID because of research. It'd be worth what are the differences, Anoop, that you've seen over the course of the history of COVID in the last year?
Oh, completely. So, the journey of a patient, even before they come to hospital, by the time that they're discharged home, research has paved the way for everything we do. From research, from knowing what levels of oxygen are dangerous, what and how much oxygen we need to prescribe, whether it's safe for patients to be managed with COVID in the community with these oximetry trials, By the time they get to our respiratory ward, what treatment do they get? They get remdesivir in some individuals, they get dexamethasone, they get oxygen. Some people get antibiotics based on the research and the blood test that allows doctors to do that. And then once patients, unfortunately, if they do become sick, we have research studies that allows us to test the different types of oxygen and how much oxygen they might get, and also the positions, about lying on your back, lying on your side, lying on your front, but also in the intensive care unit, there's convalescent plasma, where we know that some other treatments have been approved. Do new intravenous drugs reduce the inflammatory response and allow people to survive or go home back to their loved ones? So the whole journey of looking after COVID has all been paved by research, and research really is like a torchlight, it's showing us the way about how we're going to treat people with COVID infection. And without that torchlight, we'd still be, fiddling in the dark. So we need research to tell us what treatment to give all our patients.
And just to come back on that, Ali,
Yeah.
we're going to have some more vaccine trials coming down the line for people to take part in, and we're really hoping people from the ethnic minority, Black and Asian communities are going to take part. They're not going to be, as we go forward, because we've got the vaccine deployed, we're not going to be testing them against dummies anymore. We're going to be testing them against the vaccines. So you'll either get one of the approved vaccines or you'll get one of the new vaccines. So that's really important for people to understand, because people can step up and say they'll come and take part in the trials, and they'll either be able to have one of the ordinary vaccines. It'll be random. You'll either get one of the ordinary vaccines or you'll get the new vaccine.
We've seen some of the vaccines not working as effectively against the different variants. For example, we've got a South African variant. We've even got a Kent variant. Are we going to get a Hampshire variant or a Southampton variant? Or,
do you know why?
How does it work? Why is the Kent variant called the Kent variant? It's a variant as far as I'm concerned.
Yeah. So listen, the variant, unlike the virus itself, which we're not allowed to call by where it was discovered, and we have to call it SARS-CoV-2 or COVID-19, right? The variants are simply where they were discovered first, and the virus is replicating so often in so many people.
Okay, explain the variant, because I mean, if it was in human terms, explain a variant.
Okay,
like, is it you got the COVID-19 wearing jeans across the country, and then the Kent one is wearing plimsolls? What's the difference?
The difference is the spike protein, is the way that the virus replicates itself. It just changes the spike protein a tiny little bit in order to try and stop immune systems fighting it. And actually, what the Kent one's done is not make itself more dangerous, but it's just made it easier to transmit. And that's what happens in every virus. So there's loads of mutations, thousands of them all over the world. And we've got such a good system of detection in Britain. We find them very quickly here because we're doing the research and the science. So people don't need to be worried about the mutations at this point in time. All of the vaccines.
Why shouldn't we be worried? Because the stats are showing that the vaccines are not as effective.
No, people have to understand the information, and it's been really confusing. The vaccines are just as effective against stopping going to hospital and death. The difference the vaccines are making between the variants is whether they transmit between people as much. So listen, if we go back to what I was saying earlier on, if we've got a vaccine that stops hospitalization and death, and we immunize all the adults in the population by the end of the summer, we'll go back to normal almost in the autumn. People will still be wanting to be careful and a bit anxious, but we won't have to worry about going to hospital or dying, even if the mutations are there. If we're lucky and the vaccines stop transmitting between people, then we might actually get COVID to go away for a bit. But we're not worried about the overall effect on death or hospitalization. The vaccines will stop that, whether it's the South African mutant or the Kent one or from wherever.
Dr. Al-Zatani, many people don't want to take the vaccine. They're not comfortable with it. So if the vaccine is effective, and all those who want to take it, they do get to take it, and they've taken it, which is around 80% of the people. And as Saul was saying, if everybody takes it, we'll be fine. But if the other 20% don't want to be forced to take it, how much of a risk are they at? Because the risk has come down so much.
Well, it depends.
At best, they'll get like mild symptoms or maybe no symptoms, and the unvaccinated population, do they still need to be vaccinated? I mean, is this going to be forced on us?
There is few things there. One of them is the age group of that group who does not want to be vaccinated. Two, how they're living in communities. So the worst case scenario, if you have a group of elderly people living in a care home who have a lot of comorbidities and they don't want to all take the vaccine, that's the worst kind of combination you can have. Yeah. So obviously, children at the moment are excluded from vaccination, but we know that they are less likely to be affected by it. They are healthy, and they are a small group. So if the 20% are all from the age population with comorbidities, let's say from the BAME community, they live in reasonably close knit families, we are looking at a big problem here. And uh, therefore, I think we have to be very careful about how this lack of uptake in vaccine and which communities are being affected. And we can see straight away that there is already now a discrepancy between BAME and non-BAME communities. And I think that in itself is worrying, because we may end up having a group of the population all suffering badly as a result of them collectively not interested in having the vaccine, because they're all close to each other. It's not like we have one here, one in the next city. Let's say the whole neighborhood here does not take the vaccine because of some misconception or
I mean, last week when we was doing the first section of this program, one of the big things was trust, and
Yes.
one of the questions which is coming up, trust especially in the BAME community, and one of the things coming up now is that they're going to secretly try and vaccinate you.
Well, it's obviously we are living in a country where we have freedom and we are not in a draconian, system where things are forced on you. But I think we have to appeal to the people's common sense and good nature and give them as much information and get people trusted from within those communities to promote it. And I think some of the places where the temples, the gurdwaras, the mosques, the churches are used to promote the vaccine to those communities with their community leaders leading the way is the way forward. And I think this is where we are going to win the battle long term, because it may be that we may be looking at some boosters and we are looking at sort of.
Poor Raymond's gone again.
Professor Johan, you want to pick up on that?
Yeah, I think it's really important. So what we don't want is a population that are at the highest risk of death from this virus, but who are the most reluctant to take the vaccine, because that's just, unfathomable. And there are many reasons why a lot of our, a lot of people from our ethnic minorities are doing that. Hopefully we've dispelled a lot of that misinformation around there. So I would encourage people to review the vaccines in two ways. Number one, BME community is highest risk. So why would you not want to have the vaccine if it's going to stop you from dying from the virus infection or being admitted to the hospital? But more importantly, it's also about community, because the virus spreads. And even if you've had the vaccine, we will reduce the chances of the virus spreading from one person to another. So if you have a small proportion of people within the community who have not had that, there's a good chance that they're more likely to transmit the virus to others as well. So this is not about just personal choice, it's about community as well, and reducing the infection risk across everyone. That includes friends and families as well.
But we've seen pictures of, these mass graves or the big Nightingale hospitals, or Southampton Airport was almost transformed at one stage, one end of the field, but they never got used.
Yeah, so that's
that's a good thing. Don't get me wrong, that's a good thing. But
can I just?
It was scary.
Can I just pick up on a thing you said a minute ago, Ali? Before I think Eamon was going to say this as well before he got cut off again. You can't immunize somebody in secret. You can't give somebody a vaccine secretly. Somebody has to sit there and let their arm out, and you have to put a needle in. So people don't need to worry about somebody sneaking around giving.
No, I think the point I was making was, for example, if you're going to give the MMR, for example, you might have included the COVID vaccine in the vial, and people might not know about it.
But it's not going to work like that, because the vaccines are very individual medicine products that are only allowed to be produced in a very controlled way. And if they ever do merge any vaccines, it'll be in the future, and we'll have had to do a trial. So the ones that might make sense.
So there is a chance?
Well, the only ones that make sense to put together, Ali, what are the ones that we might want to give at the same time? So flu and COVID, but not this year, because we've not done the trials, and no company is making a dual vaccine this year. And it's very likely because
what is the chance of that happening?
In 5 years' time, in 10 years' time, the companies might be doing that if we still need COVID vaccine, but not in the next 4 or 5 years, because we need to understand more about how to use the COVID vaccines themselves.
Dr. Al-Sultani, you wanted to come in on that one?
Yes, I think we have to be wary that since World War II and the Nuremberg trial, we have set up a code against human experiments. The humanity has gone through a phase where the people have conducted kind of this unethical research, or trying to force people to have medications or treatment or experiments without their consent. And we will not go back to that point where we cannot practice safe and ethical medicine, and giving somebody a drug against their choice is not something which not any of us will promote. And I think as a humanity, nobody was going to go back to those dark days where we can treat anybody against his will, or vaccinating against his will. And we have to accept that. And this is human choice. And I think people should rest assured that nobody will force anything on them without their permission. And we just have to face the consequences. But like what Anu was saying, we all will have to pay a price for if the few do not look after the majority. And we're not safe until we're all safe, to be honest. This is where we
Okay. If I could start with yourself, I'm going to put a question to all of you guys. Dr. Al-Sultani, how important, we've seen people from the mosque, from the leaders from the mosque, from the gurdwaras, from the mandirs, from the churches, from literally every faith institution. How important is it for faith to be a part of this, to promote the vaccine? Does it need to be a part of it? Should it be playing a role? Or what's the relevance of faith being in this line?
I think any community where there are some moral, spiritual leadership, where there is people there where people look up to, should be leading by the example. And I think using those people, using the venues where communities traditionally meet, to promote the healthy message, which we should reach out, should pass on about the vaccination, about the isolation and common and social distancing, face, space, and hands, and all those things. I think the more that message is repeated, the better we will get at it, and the dispelling the myths which are out there. Because unfortunately there's so much out there which we need on a daily basis to combat, and people will see who's in front of them directly, and that will be their imam, their priest, their temple person, and I think that's where we need to put a lot of effort in particular with the BAME communities, to promote this and to get the message across.
Professor Chan.
It's absolutely vital that they play a pivotal part in it, but it's not just them, it's all of us, everybody in the community, our neighbors, our friends, our colleagues. We all need to play that part, make sure that we don't spread any misinformation, give people the right information. And part of that is all our religious leaders. But also we know that what a toll this has had on people. People have not been able to go to the gurdwaras and the mosques and the mandirs. So if we want to go back, we need to have the vaccine. So it's really important that all our religious leaders promote vaccine. Otherwise, people will be delayed by the time they ever get back to it. So really, for us to practice our religion in the same way, with the same freedom we've had before, vaccine is absolutely essential to that.
I mean, just very quickly, if I can just pick up on that, should we have, like, if you've had the vaccine, you can come in, and if you haven't had the vaccine, wait outside?
I think it's been really good to listen to the government minister for vaccines talk about the need for equality and giving everybody the opportunity for having the vaccine before we start having special things for people who've had the vaccine, like vaccine passports for holiday. I think that equality, that everybody feels they're being treated the same, is really important. We're giving the vaccine for clinical priority, and that's the order, and then down it'll be decreasing age. And I just want to repeat what Anoop and Eamon have just said. It's so important for us all to get our vaccines and talk about them positively. Young people, to put older people's minds at rest, help them go and get their vaccines, have our own when the time comes. Because by doing that, as the other guys have just said, that's the way that when we get to the end of the summer, we'll be able to have a more normal life in Britain. Even if the rest of the world hasn't caught up, we've got this amazing opportunity that we've got the vaccines that we're giving to the population now.
We're fast running out of time, but I want to sort of ask one last question, and that is that I haven't personally seen or heard of any faith institution coming forward, or whether the Public Health England has approached any faith institution to be a vaccine centre. What would you say to either of them? If I could start with yourself, Dr. El-Sultani.
Well, I know there are some centres in the Midlands and
yes, indeed, but here in the south we haven't had it.
I think the question is whether there's any logistic related to it, but I have spoken to some of the GP leaders about that, and I've spoken to some of the Muslim community leaders as well about that. And so I have put the proposition to them that would you, and even one of the Hindu temple community as well about that. So I have actually put that proposition to them. Now,
I mean, would that not help?
Well, I think it will help, and I think if like Saul was saying, that if you get to the age range where the government says that now it's good to have the vaccine rolled out to a bigger community of people, and we think it's worthwhile then having that center, because at the end of the day you have to weigh the logistics of having a center and how many people are going to vaccinate in it. You need hundreds of people to be using that center, and I think not only the people of that center, but the people around it as well, so that it can be
well, if I tell you that Southampton, just as an example, has a population over 215,000, and the BME community is just over 3%, I think that's a lot of people.
Yeah, but listen, Ali, I don't think we should get fixated. The NHS is doing a really good job at getting the vaccine to everybody. So I think it's really good for new vaccine centres to open. I
mean, we've emphasised a lot on why it's important for the BAME community. So why should BAME institutions not be used as vaccine centres? And they have been doing up north, where admittedly the population is bigger, the BAME community population is bigger, but have they or haven't they been approached here in the south, Professor Chauhan?
So I would have no problem with that at all. I think whatever it takes in order to make sure that we give access to vaccines for all our people. We've seen people become very innovative across the country. We've seen buses, vaccination buses, go around in the Midlands, and we've seen other places of worship being offered. Yes, we are slow in the south, but I can see it coming. And I would say that if this is what it's going to take in order to try and get our BAME community minority to come, I would promote it. However, having said that, the vaccination that they receive, whether it's in a gurdwara or a mosque, is going to be the same vaccine that they get in a hospital or a GP. So while we've got the chances and while we've got those vaccination hubs open now, why wait? But it's an important point that you've raised, and it's something that I would personally support.
Brilliant. Thank you so much, guys. Is there anything any of you would like to add?
No, I think it's a lovely way to end.